Right. Thank you so much for the introduction, that Nchabeleng, and thank you everyone for joining us today. My role today is to just tell you guys about Quadcare, which is the main business that I'm involved in, as Quad standing for quality, accessibility, and dignity. We are a network of medical centers mainly across Gauteng. 9 of our centers are in Gauteng, and one is in Mpumalanga, in Siabuso. So the aim of our business is to do exactly that, provide access to quality healthcare that upholds patient dignity. Yeah. Right. And we have our hashtags there, like if you see us on the social media spaces. And also the reason I have a dark background is because I'm load shedding while I'm presenting. So please bear with me. Unfortunately, you can't see me very clearly. But yeah, for social media spaces, our hashtags are feel better, hashtag also safe spaces, and hashtag care with love, because we believe that is very, very important, especially if you look at how healthcare is provided to low income communities. So we want to create spaces where people of whatever sex, sexuality, gender, like social status, financial status, can come into a space, feel safe, feel better, and feel that they are cared with love. Basically, how I went into private medicine, it really started many years ago when I was 6 years old, and I was with my grandmother in our township, which is Temba, and she said I must grow up and become a doctor so that she doesn't wait for such a long time to get healthcare, and that is what, like, that message was very clear to me at that age. I made a decision at that age, and I grew up to realize that this is the story of many grandmothers, across our country, and many different people, So my first medical practice was in Vryburg as a sole practitioner. I was in that village of Vryburg, managing the healthcare, in that area, and realizing really the issues around rural healthcare, including how many people leave rural areas to go work in mining towns, and then like come back end of the year with like some illnesses, including HIV, including TB, including pulmonary diseases, and become like real burdens of the community, and the community has to take care of illnesses that are really like, or that people contract in places far removed, from them. And then I went on to study other things, and found myself really involved in the business of primary health, occupational health, and sports medicine and wellness, and trying to put everything together to make sure that healthcare is accessible to people in South Africa. So our credo as Quadcare is we believe that everyone has the right to quality healthcare and to information that allows them to make the right lifestyle choices, because we believe when people do better, know better, they do better. We believe in preventative medical care, empowering healthy and happy individuals to create healthy communities. We employ compassionate and ambitious individuals who consistently strive to provide the best care and who give patients the best experience for the lowest possible price. This ensures the growth, sustainability, and longevity of our business, and enables us to expand our network and maximize our impact on the lives and well-being of people. So when UK like became Quadcare, it was when a consortium of investors came into the business, and they brought with them experience in other fields, outside healthcare, experience in retail, experience in property development, experience in just healthcare systems in terms of information technology. And because of that combination of skills, we have been able to build a business that we believe can be sustainable, in the long time. And in the short space of time, the investment came in 2019, and we grew from 3 clinics in 2019 to 10 clinics today. So like I'll just jump like to what our purpose is as a business, just to be a trusted brand in providing access to quality health services. And this becomes very, like, when I talk about a trusted brand, it becomes very important, because this is what allows us to build some of the relationships that we have built over the years to allow us to provide this care to people in an affordable way. It can be like, you know, collaborations or relationships with government, for instance. You know, because of that, we've been able to provide like circumcisions, for instance. We've been able to provide baby vaccinations, and from collaborations with other NGOs, we've been able to provide free HIV treatment and care, you know, to people. So what our MO has really been has been to try and build a brand that everyone, like all the stakeholders, can trust and collaborate with, and see how to positively impact like South African people's lives. So we are primary healthcare practitioners, and we make sure that we always act in the best interest or well-being of our patients as our professional duty. And and the patients then put their trust in us, and we make sure that we honor that and not abuse our position. Abusing our position becomes very important, especially when you look at services like trans healthcare, you know, where we feel like, you know, healthcare for a long time has been quite paternalistic in its approach to managing, you know, some of the gender diverse or sexuality diverse, you know, populations, and we come in and say, this has to be different. You know, you need to put the patient's needs like, you know, above your own, and make sure that you are providing the care that they go out you know, seeking, and you make sure that you're doing this in a professional and dignified way. And we make sure that our personal beliefs do not prejudice our patients' healthcare, and beliefs that may prejudice the access to healthcare for many people would be like, you know, prejudices around race, culture, ethnicity, social status, lifestyle, perceived economic worth, age, gender, disability, sexual orientation, religious, and many reasons that become people's barriers to accessing healthcare. You know, so we make sure that we work with medical professionals who are sensitized. You know, we make sure that all our professionals are sensitized to deal with diverse people, and make sure that we provide like a great level of care. We hire nurses as providers, we hire clinical associates as providers, and we have a supervising medical practice, like we have the doctors as the supervising medical practitioners, you know, to make sure that we try and keep things as affordable as possible for our patients. We believe in continuous development through the different trainings that we provide, you know, to our medical staff, to make sure that they are constantly improving and gaining the skills that they need to be able to provide the care. We like I did talk about the supervision of the medical doctors, and like just ensuring that the supervising medical doctors are immediately accessible, you know, to all the practitioners, and we use technology to ensure that this immediate accessibility is possible. And we develop clinical protocols that we review, you know, all the time with our supervising medical practitioners, and these are based on the essential, on the EDL. Everyone here, I guess, knows what the EDL. So we make sure, like, you know, our protocols are as per the EDL, and we are reviewing them all the time as we see like different patients. And we believe in working collaboratively with practitioners in our area. You know, it may be specialists, it may be just like, you know, another GP down the street, it may be the local clinic, but we believe that like the problem of access to healthcare is so huge in our country that we all need each other to make sure that people can access health services. You know, so the role of technology becomes very important when it comes to the patient journey. In our practice, we use Google Sheets to make sure that our things are always like, you know, online and in the cloud, and we are as paperless, as much paperless as we can be. You know, like we used Google Sheets, we have the health bridge system that we use, for managing clinical excellence and making sure that we are able to do, like, you know, the accounting things, like your invoicing and your submission to medical aids or submission to like organizations or corporates that we may be working with. We use a zero accounting system to and all these things together, we use them to monitor clinic activity like all the time. We monitor patient waiting times, and as a guideline, we make sure that patients should not be waiting to be seen for more than 10 minutes after they walk in the door, you know, and once they have been captured, they should not be like, and once they enter the consultation room, we, for instance, have a guideline of around 20 minutes with a patient inside the consultation room, but we do understand that patients may present with different things, but those are like usually the points of discussion when we have our clinical meetings to understand why, like, you know, certain patients like, you know, experience this and things like that, you know. So it's a weekly meeting that happens with the clinical team to make sure that we are always monitoring what is happening in our clinics. And we make sure that all the consultations include full history, physical examination, medication dispensing within the limits of the expertise of the clinician that is seeing the patient. And there's always the backup of the supervising medical doctor when there is a need. And with the time spent on procedures, we take that into account when we're assessing the efficiency all the time. You know, so all the clinical notes are entered on the IT system, and we make sure that they are full and comprehensive, and they are immediately entered to allow for the claim submission, but it also allows the head office to immediately see what is happening, you know, in the different clinic. And because we also always emphasize to our clinicians that clinical notes are legal documents, and they need to always be, you know, comprehensive. So, and another thing that's important in a patient journey is the patient feedback, you know. So we have like WhatsApp lines, like a Feel Better at Quadcare, like, you know, email line. We have telephone lines that all the patients have access to, and they can contact us at all times to provide feedback, whether positive or negative, and we are able to immediately, you know, act on that feedback, because I think if we are talking about like a level of healthcare that we want our patients to be experiencing, we need to make sure that we have that feedback from the patients to make sure that we are doing what we say or what we claim to be doing. Thank you very much.
Thank you, Doctor. I'm going to allow 2 questions for Dr. Rakumakoe while she's still on the platform. Anyone with a question? I'm going to take only 2. Okay, in the absence of one, I'm going to request our next panelist, that is Ms. Jackie Maimin. Jackie, up to you.
Thanks very much. I'm just going to put my screen into presentation mode. Can you see that? Sydney?
Yes.
Okay, super. Thank you.
Sure.
All right, so my talk is on pharmacy-initiated management of antiretroviral therapy, and I'm going to try and keep to my 20 minutes. There's so much to tell everybody. So globally, there's about 38 million people living with HIV, 68% of them in sub-Saharan Africa. Only 68% of these people are on any ARVs. And in 2019, nearly 700,000 people died of an AIDS-related causes. So South Africa, as we know, has got the highest adult HIV prevalence at 18% in the sub-Saharan Africa, and the largest adult population of people living with HIV in the world. And it's estimated to be at approximately 3.5 million people. So here in South Africa, on average, there are more than 200,000 new infections every year. And HIV remains the top five of underlying cause of natural deaths, contributing to 4.8% of all deaths annually. And this is despite programs such as NIMART and treatment points throughout the workforce. Basically, there is insufficient capacity of the current workforce tasked with managing HIV, as South Africa keeps missing its HIV targets. So what are the costs? Well, the estimates by National Treasury and the Department of Health are that 75.9 billion rand will be spent on the HIV sub-program in the current medium-term expenditure framework. And this is just unsustainable. So South Africa is not winning the war against HIV. And this is placing a huge burden on the public health system and straining our fiscal resources. So although there have been substantial gains in recent years, and here we talk about the expansion of ART eligibility, the adoption of WHO recommended task shifting, universal test and treat, the Ccmdd. However, many health systems across sub-Saharan Africa remain weak and under-resourced. So there are many research articles published in South Africa that demonstrate that task shifting, such as NIMART, delivered at a primary healthcare level, is as good as or better than outcomes of similar patients who are maintained at a hospital-based ART clinic. Unfortunately, even with the introduction of NIMART in 2010, HIV prevalence has grown from 5.5 to 8.23 million people last year. We really are not winning this war. And this burden on the public health system and the fiscus just keeps growing. The many countries across the globe are now deploying pharmacists as part of their healthcare professionals treating and preventing HIV infections. And South Africa is not new to the idea of an expanded scope of practice for pharmacists. Family planning and primary care drug therapists have been successfully utilized since the early 1990s, and the COVID-19 vaccination rollout over the past year has been driven by pharmacists delivering more than 10 million vaccinations in the private sector. What's the next step? Well, we believe that it is pharmacist-initiated management of retroviral therapy. The PMART was realized through a consortium of partners, including the Southern African HIV Clinician Society. And we had specialist clinicians who assisted us to develop the training content and the guidelines. And there you can see 6 of those specialists that were involved. The PMART curriculum was engineered using the highly successful NIMART curriculum as the foundation. The added benefit being that pharmacists have in-depth knowledge on pharmacology of ARVs. The PMART curriculum includes 18 modules or 160 notional hours, which is 15-day face-to-face theory course. The NIMART module is the NIMART course is 20 modules, and the difference is there are certain restrictions on PMART which are not there in NIMART. And you can see there's MCQs, there are online case studies, there are assessments and summative assessments, and basically all of this needs to be put together with a portfolio of evidence and 10 supervised cases. And the exam, the final summative assessment, has to be passed with at least 80% pass rate. Task is a huge one that will require every possible healthcare professional that we have. And here you can see a summary of the provincial HIV testing and ART initiation targets. These were for 2018 and 2019. We can see Johannesburg as a high burden district, population of just over 5 million, HIV positivity ratio of 0.11. And here the target is 1.2 million HIV tests with an expected HIV positive ratio of 139,000. Well, in the Gauteng area, there are 1,314 pharmacies. So think of this. This is an extra 1,314 possible treatment points. So HIV and pharmacy. Pharmacy clinics already offer HIV counseling and testing. We've got medical schemes that cover point-of-care testing and ARVs. Pharmacists dispense ARVs. HIV counseling and testing is within the scope of practice of pharmacists and pharmacy nurses. Pharmacy is very much an underutilized resource, and there's an opportunity here to reach untested and an untreated populace. Pharmacists and nurses can enjoy an expanded scope of practice if they have undertaken training of an approved course, registered this with their statutory council, and then applied for a Section 22A15 permit from the DG. How can pharmacy help attain the 95-95 targets? Well, we've got a wide footprint of pharmacies, even within the rural areas. Pharmacies have got extended trading hours, which increases access because you don't have to go to a state facility clinic, which may only run from 9 till 4. We're open 7 days a week, very often into the late hours of the evening. We represent a large pool of healthcare professionals, established logistics and supply lines. We've got advanced information systems. Our facilities and our personnel are regularly inspected by the South African Pharmacy Council. We adhere to strict clinical boundaries around care provision. Our clinics offer point-of-care diagnostics and monitoring. So there's access to pre- and post-test counseling by healthcare professionals and access to confirmatory HIV testing. Access to chronic medicines, dispensing or via the Ccmddd project, and strong referral links to doctors and specialists. What are the unique opportunities for engagement from a pharmacy perspective? Well, firstly, pharmacies represent a non-stigmatized environment for engagement with that hard to reach or missing middle population groups. An example is emergency contraception requests. So currently in pharmacy, in the private sector, we have requests for about 100,000 morning after pills a month. So these are instances of unprotected sex. So it represents possibility of speaking to 200,000 people about PEP, PrEP, or getting tested and knowing their HIV status. Pharmacies do family planning consults. Here's an opportunity to speak to young women. We have well baby clinics and EPI. Again, we've got young mothers. We do minor ailment treatment. So it could be anything from somebody with a hangover to colds and flu, where we see a lot of sportsmen coming in for athlete's foot, men coming in for libido enhancers. The dispensing of prescriptions. We see acute and chronic prescriptions, and these all represent opportunities to speak to people about their HIV status. Screening for HIV. So a lot of the medical schemes have health risk assessments, which include an HIV test. Then wellness screenings. Pharmacy clinics screen for diabetes, high blood pressure, cholesterol, and pregnancy. We do a lot of different screenings. Vaccinations, we do flu vaccinations, COVID vaccinations, and travel vaccinations. And then there are the national campaigns, for instance, World AIDS Day. And then lastly, we obviously are a touch point for people addicted to drugs of abuse, where we do needle purchases or needle exchanges. So, SMART, what is the plan? The plan is to develop best practice clinical guidelines for pharmacists and pharmacy-based nurses. And these will be informed by global HIV experts and research. Plan is to develop high quality training on NMOT and PMOT for pharmacy-based nurses and pharmacists, and to bring on board PMOT pharmacies across South Africa, to provide online support to newly trained pharmacists and pharmacy nurses, including real-time guidance from clinical experts. And we do a lot of this via the Vula mobile app. To customize digital platforms for pharmacies and patients with treatment algorithms, and to market the availability of these new services to target markets. And this could even be to women who sell sex. It can be to men who have sex with men. So there are many target markets. So what is the eligibility for PMARD in particular? So in HIV negative people who test negative, they could be PEP for needle stick injuries, HIV exposure and sexual assault, PrEP, which is on request and after a risk assessment in high-risk people, and for HIV people that test positive for HIV in the pharmacy, they would be ART, first-line therapy initiation, and this would be in people over 15 years of age and that have got a CD4 count of higher than 200. So what are the PMARD referral criteria? And I think this is very important. The whole idea of PMARD is to be conservative. So pre-ART initiation, exclusion from PMARD with referral to the appropriate healthcare professional includes all children under 15, all those over 15 but that weigh less than 35 kilos, a creatinine clearance of less than 60 mils per minute, pregnancy, any symptoms of TB, CD4 count lower than 200, WHO staging at 3 and 4, and symptoms of opportunistic infections. Any of those will be immediately referred. Smart pharmacists also refer patients requiring treatment for STIs, that's other than vaginal candidiasis, oral herpes, and scabies, treatment of comorbidities, contraception, except emergency contraception, unless the pharmacist or nurse possesses a Section 22A15 permit for family planning. And then, of course, hepatitis B positive. So, first-line regimen prescribed by PMARD pharmacists would be combinations of tenofovir, lamivudine or emtricitabine, dolutegravir, or efavirenz. There will be no second or third-line regimens at PMARD level. And as I already said, treatment will only be initiated after receiving the renal function and the CD4 counts. So we are not doing test and treat. A summary of PMARD and appropriate task shifting. The PMARD will help South Africa meet its 95-95 HIV commitments, in my opinion. The program leverages on an opportunity for high-risk patients to access HIV testing and care within private pharmacies. It optimizes the extensive pharmacy network and an existing private GP and state clinic referral system. It provides support to both pharmacists and GPs for active case finding and referral. It is a natural evolution of task shifting from specialist HIV care in the early 2000s to GPs, subsequently to nurses, counselors for testing, and now to pharmacists. It is designed by South Africa's most experienced HIV public and private sector specialists and generalists. It has oversight by doctors at every level and incorporates real-time monitoring and evaluation, and is based on supplementary training with knowledge evaluation and strict treatment algorithms. Thank you very much.
Thank you so much, Jackie. Let me first apologize, Jackie. I hope you'll forgive me. I didn't introduce you properly to, to everyone. Can I just steal this moment to introduce you? Jackie is a graduated with distinction from Rhodes University and is a pharmacist with 35 years working experience in the health sector, specifically in pharmaceutical industry. Jackie is a fellow of the Pharmaceutical Society of South Africa. She is an elected member of South African Pharmacy Council, serving her second term, where she sits on a number of committees and chairs the practice committee. Jackie was a founding director of Independent Community Pharmacy, Association and is currently the CEO. My apologies for that. I'm going to allow 2 questions, only 2. If there's any more, we will do after all the panelists have rounded off. Can I have 2 questions? Okay, thanks. Thank you so much, Jackie. I'm going to go to our 3rd one. That is Mrs. Maggie Munsamy. Maggie, I won't make the same mistake I made with Jackie. I'll introduce you properly. Maggie is a professional health specialist with combination of skills and experience in health management, financial management and accounting, international liaison, organizational development, procurement, as well as change management. Instrumental in developing the first medical case management system in South Africa, created the inaugural minimum data sets for geriatrics in South Africa, established a cutting-edge medical payment system. Attaining cum laude and distinction in various of her qualification, graduating as one of the top 20 best students in her master's degree from UNISA School of Business Leadership. A laureate of the Women Leadership Award for the from the South African Police Services. Currently, she is the technical specialist in the National Department of Health and head of the Central Chronic Medicine Dispensing and Distribution, which normally is called Ccmddd, the flagship program of National Health Insurance. Also, she is the winner of the CPSI Innovation Award in the health category and has been crowned the ultimate winner, earning the title of Innovator of the Year. This is the brief summary of all the good things that Maggie Munsamy is. Can I hand this to you, Maggie?
Thank you so much, Sydney. Good evening, everybody. Thank you for attending this. I see there's quite a large number of people that's attending. So let me start. Today we're going to give you an overview of Ccmddd. And of course, we always need to go back. We need to see why did we go about doing Ccmddd and what it is all about. I'm sure many of you are very aware of the public health sector. And of course, the picture tells you 1,000 words. And if we look at the clinic, it is over flooding and it is just bursting at its seams. So what can we possibly do? So traditionally, the patient went to the medicine. Ideally, the medicine should get to the patient, but we know that this is unaffordable because we have a terrain like this. And if you look at the countryside, urban, rural, it is quite difficult. So we have to come with a compromise. And so we have the patient and the medicine to a convenient location. So that is what Ccmddd is about. So Ccmddd, we implemented it in 2014. We started in the 11 pilot sites, and we very quickly expanded to the 46 districts, all provinces except for Western Cape. Now, we do know that there is a great potential for growth. We do know that there's more than 7 million people living with HIV. We also know that more than 13 million patients are treated for chronic diseases. So currently, there are 2 service providers. The first one is Pharmacy Direct that services KwaZulu-Natal, Mpumalanga, Limpopo, and Northern Cape, and DSV services Eastern Cape, Free State, Gauteng Province, and Northwest. And then also, if you look on the side, you will see that we have branded Ccmddd. And if you keep on saying Ccmddd, somebody always misses out the first C or the last D. And so that is why we speak about the rebranding, which I'll talk a little bit later. Now, what are the objectives of Ccmddd? So we will improve access to chronic medication, you decrease stigma, and improve quality of care and service delivery. You reduce the workload in the public health facilities so that they can give the care for the ill patients that is coming, and you improve the patient experience in the collection of the chronic medicines. You reduce patients' waiting time, and you decongest the facilities. There's improved reliable data to inform your decision-making, whether it's at facility service providers or pickup point, or even at the National Department of Health. We have improved treatment adherence and improved supply chain processes, and also improved patient satisfaction and knowledge of care. So this is the patient's journey. A stable patient will go to the facility. They need to meet the criteria. 1 is that they need to be stable, and 2, they need to have an ID or asylum seeker or a passport number. And the patient agrees to be on Ccmddd, meaning that they have to give consent to be on the program. And the patient then selects an approved pickup point from the list that is given. A 6-month prescription is created. This can be either manual or through the electronic system. And the first dispense, whether it is 1 month, 2 months, or 3 months supply, is given at the facility. And then the patient collects the rest from a chosen pickup point that is either closest to their home or it is the most convenient for them. And 6 months later, the patient returns to the facility. However, if the patient in any of these stages decide that they're not feeling well, they are most welcome to visit the facility. So this is the high-level process that I want to take you through. And firstly, you will see in green is public sector, and then the red is private sector. So a patient visits the facility. The patient is stable. The clinician identifies that the patient is stable and meet the criteria. The other criteria also means that there must be certain medicines that is on the formulary so the patient can go into Ccmddd. A 6-month script is then written, and it is taken to the courier or service providers, either electronically or manual, to the central point, and where it is pre-dispensed, and the courier then takes it back to wherever the patient chooses, either at an adherence club or an external pickup point or a facility fast lane. So this has been the growth since we started. And as you see, from 2014 till current, we have been consistently improving on the numbers, but more especially, we always exceeded the target that is set. So which means that there is a lot of patients that is coming into the program. This shows us the number of registered patients, and they continue to grow. And if we look at the different provinces, and then you can also see the number of facilities that is registered. These facilities include the primary health care and also some hospitals, and the number of patients that is registered. Currently, we are sitting on 1.2. This number is just increasing by the day. And this slide tells you or talks to you about the external pickup points that we have contracted. The external pickup points in each of the provinces, and you can see that there is significant amount of pickup points in Gauteng and KZN, as well as Limpopo and in Mpumalanga. And then we look at the patients that is collecting at these pickup points. It's almost 61% of the patients that is registered with us. And at the bottom, you can see that on the blue line is the patient that is collecting at an external pickup point. And the green one is from the facility fast lane, where you can see that the line is slightly decreasing, and that is because of COVID. A lot of the facilities opted to put the patients into the external pickup points. And the red one at the bottom, you can see it's also going down a bit because, again, most patients do choose to go to an external pickup point rather than being at a facility. This slide shows you the type of pickup points that we have. So right at the top, you can see that we have the corporates, and we do have a significant number of them throughout the country. And then we have the pharmacies, and then we have medical practices, and we have the post office, and we have numerous NGOs. We also have the prefabricated units. We also call them containers, and also other innovation like your smart locker. We have business premises. We have the home delivery model. We have nurse practitioners. We have kiosks that could be possibly inside of a mall, example at MediRite, and inside the pharmacy or next to the pharmacy, you can have a kiosk. You have a mobile van, you have occupational health clinics, and you can also have place of worship and the war rooms. Now, this tells us that how we have moved from being in a facility to all of these external pickup points where patients can collect at their own convenience. And of course, it is free. Now, I think most clinicians will identify with this, a script that we cannot read. So if you cannot read, how can you dispense it? And of course, with illegible script comes problems, which means that if you interpret something and you issue it, it just means that it could be the wrong one, and it has happened. Of course, again, another illegible script. And then what about what is prescribed as opposed to what is dispensed? And as you can see, this clinician did prescribe epilepsy. And of course, the epilepsy was dispensed. See, we have lots of fun in our section. So what are the top rejections for these scripts? Most often, it is around the dosage and directions. Then we have the patient's detailed rejections. We have the prescriber detailed rejections. Sometimes they don't add in the number, or they don't sign, or they use someone else's prescriber details. And then we have the facility, or there's no pickup point details. And then the repeat rejections, meaning they write a script for 1 month and you expect that to be repeated. And then it is also on a policy or code list rejections, meaning that in certain of the provinces, if that item is not there, it also has to be rejected. And then of course we get a prescription with absolutely no medication. Of course, with our intervention plans, we did have we were just discussing this today with Doreen and Merlin, 2 of my colleagues that is with me. And we said in a matter of 3 months, the rejections that was from almost 14,000 dropped to 7,000. And currently it is just about 200. Now, this is all thanks to our electronic system. Now, this is our new branding. I do hope that many of you all have seen it. It is the same great benefits. We're improving service delivery, and also it is free, safe, quick, and convenient. So what is double-up meds and how do you pronounce it? So we just say we all like shortcuts, so it's called double-up. So it is a colloquial term meaning shortcut. So instead of sitting in the clinic for many hours, the patient can now use double-up meds as a shortcut to their chronic medication. Now, in this slide, we want to show you what our plans are in terms of the bigger picture, where we are and where we are going to. Now, if you saw my previous slide that we just spoke into the inner part of this, and then we look at on the outer part, I think the first one would be the creation of this unit, which is the procurement side. I'm just waiting for, oh, there you go. And here we look at firstly the health products. Currently Ccmdd is all about just the medicines, but once we get the health products, then we'll be able to service a much wider range of patients requiring products. It could be also your sundries, your catheters and stuff like that. And currently each of the medicine procurement and supply chain is sitting at each province, and the Ccmdd orders through the province. But if we have an additional link, which is the private health, and the private health would be able to also procure from the public sector. And then if you look at the top, almost to your right, where we have private health, and in their clinics, they will be able to access this. And if they utilize our system, and if they do create their prescription or see the patients at their facility, they'll be able to link into Ccmdd by creating the 6 months prescription, and the courier takes it and dispenses it, and then it delivers it back to these decanting models, and the patient can choose whichever one they want to. Ideally, we are looking at all of the medical aids, and given that they will follow this process. Okay, I think, thank you. So those that do not know me, it is me that is holding the trophy. So we did win the GEMS Health Award. We also won the Innovation Harnessing Technology, and ultimately the Innovator of the Year. So finally, Ccmdd is a proven, successful, patient-centric approach to service patients in a manner that is beneficial to patients, departments of health, communities, and creating a lasting partnership with private sector. Collaboration, we need this. And then I say, thank you all. Back to you, Sydney.
Oh, thank you so much, Maggie, for a nice, insightful presentation. Before I give two opportunities for question, I saw on your invite there was also Doreen. I'm not sure if she's going to feature in when on question and answer session, or was she also having a slot after you just presented?
She is going to feature in the Q&A when you have broader discussions answering the Q&As, the questions.
Okay, great, thanks. I'm going to give this opportunity for 2 questions before we come to the last speaker.
The questions are on the Q&A at the bottom of your screen. There's about 10 questions.
Let's start with the easy one. The first one I am reading is, can private community pharmacy be contracted to double up meds in Eastern Cape? The answer is absolutely yes. If you can put details onto the chat and we will get hold of you, just tell us in which district you are in, and then we will contact you. The second question is, I see medical practices are one of your external pickup points. How do those private practices benefit from this? So, one, you know the patients will get used to you. Nothing will stop the patient from seeing you as a doctor, a clinician. And secondly, for every parcel that you hand over to the patient, we pay you. Even though you might think it's small, but when you look at the numbers, it can be quite substantial. It depends on your service delivery. If you are kind and caring, patients come back to you. And that's the 2 questions for now.
Okay, thanks so much. I'm coming to the Nurses Run Clinic. This is going to be presented by Sue Hoosain. Just to give you a bio of Sue, she is a network general manager for the Unjani Clinics Network. She has been with the organization for 10 years and currently oversees the operations and general management of 120 facilities. Sue, over to you.
Good evening, Chair, and thank you for the introduction. Firstly, to the South African HIV Clinicians Society, thank you for the opportunity to present our model to your guests this evening. So my name is Sue Hoosain. I'm the Network General Manager for the Unjani Clinic Network. I oversee the operations for our nonprofit organization, which was specifically established to fund, implement, and manage an initiative called the Unjani Clinic Network. Currently, we have over 109 facilities in the network nationally, with 103 being container clinics, 2 mobile clinics, and 4 health pods. We are seeing in excess of 70,000 consults monthly. Annually, about 720,000 patients come through our doors, and we were quite excited to celebrate over 2.6 million consultations since our inception. So before I continue to give you more information, I just want to acknowledge the funders that we have currently on board, and they have made the possibility of all of these clinic models a reality for us. So we are supported by a variety of funders, both pharma and in the non-pharma sector. So if you think about our model, it is about empowering healthcare. It's about empowering professional nurses and communities through health system strengthening and enhancing access to quality, affordable healthcare. So first and foremost, we empower Black professional nurses to operate and ultimately own a primary healthcare container clinic, which you can see in my presentation. And these are located in low-income communities across the country. Due to our doctor resource shortages, we have seen the need to shift tasks to primary healthcare nurses who perform basic primary healthcare services and then would refer to doctors in their area when we have patients who are out of a nurse's scope of practice. For us, we've noticed that 80% of our population is reliant on government for healthcare services. So the initiative then broadens access to primary healthcare through an innovative healthcare delivery model, which has become essential. For the nurses, not only are they empowered as healthcare providers, we support them, and they are then able to run sustainable businesses and then create employment within their communities. So these women who are nurses eventually become nurse entrepreneurs and become role models in their communities and support the communities in terms of primary healthcare services and employment. So for us, we want to change health-seeking behaviors of mothers and young people, and it's at the core of what we do. So we don't only seek to empower our nurse, but it's also about empowering the communities in which we serve. And Unjani, as you would know, is a Zulu word meaning how are you? And it encompasses not only one's health, but one's entire well-being. So in terms of empowerment, the establishment of the network, we have over 110 women who've now been empowered to own their own clinic businesses. We've been able to keep nurses as well as have nurses return to the nursing profession. And this has elevated our models quite drastically over the last few years. Nurses within an average of 6 months obviously enjoy a better lifestyle. They earn a higher income, and they're able to improve the lives of their families because of the businesses they now own. And permanent employment within the network is now in excess of 450 people that are employed on a permanent basis by our nurse entrepreneurs. In terms of reporting, we have an electronic patient management system, which allows us to then keep records and get away from a paper-based environment. You can see our patient demographic is 67% female, 33% are male patients. Pediatric patients under the age of 5 make up 17% of our profile, 6 to 19 years, 11%, and then 19 to 59 is 58%. Our 60 plus patients make up 13% of our patient pool. We also look at supporting local government clinics in terms of easing their burden, assisting with local campaigns such as COVID awareness, COVID screening. We also have partnerships in certain of the districts to assist the Ccmddd program, or Maggie, as you've renamed it, Double Up. And that is just, you know, a brief summary of what the nurses offer within their communities. As you can see, based on the current map, we have specifically selected nurses and looked at areas of where there are low income communities, communities where there is a need for healthcare services, and also where the existing healthcare structures are needing a support base. And that is how we've found nurses and selected mainly township areas, rural areas and villages to place our structures. In terms of our goals and our objectives, we are, or the initiative achieves SDG goals 3, which is good health and well-being, gender equality by creating business opportunities for women, decent work and economic growth by creating new and meaningful jobs, and then partnerships for the goals is achieving the impossible through collaboration. In terms of our services, so our nurses cover basic primary healthcare with a significant preventative focus, but our nurses also treat acute conditions, they manage chronic conditions, health education. We've just introduced circumcision at the clinics, basic ultrasound, and then all of our nurses are primary healthcare trained. They have a dispensing certificate, they are NEMAT certified, they all hold a BHF practice number and operate with both a Section 22 and a Regulation 47 permit that's been issued by the Department of Health. In terms of our scale, so our short-term goal of having 100 clinics was reached by December 2021, and we have committed funding from MSD, Merck for Mothers, as well as Johnson's & Johnson's and the Alma Foundation to scale the network to 650 clinics by December 2030. So as I mentioned in our introduction, there's 3 models that we currently run. The first one being the container structures that are funded. We then have our mobile units, and just introduced very recently is our solar-powered health pods that go out and service the community. So thank you, Chair, and the Clinician Society for giving us this opportunity just to share what we do in the private sector by allowing access to more facilities as well as patients in the communities.
Thank you, Sue.
Thank you, Sydney.
Before you go, I'll just check if there's any question from the audience so that you can just clarify.
Sure. Sydney, I do see one question from Sarah. Can these clinics operate from private pharmacies? Sarah, at the moment, our funding is based on the container or mobile structures, either health pods or the mobile unit. So we have not yet tested the concept in a private pharmacy.
Okay, great. Any more questions? I don't see any.
Don't see any. Thank you, Sydney.
Thanks so much, Sue. I'm going to check on our chat box if there are questions that are not answered yet.
I think the questions on the Q&A primarily for PIMAT. Sarah Simji, for those of us who have completed the PIMAT course, what happened? I think that's for Jackie. And Catherine Martin, what is the appropriate cost for a client for receiving art prep PEP through PIMAT? Yeah, Jackie?
Thanks very much for that. So let me just see here. So one was the people that have done, so more than 1,000 pharmacists have already been trained. However, some objections have been raised with PIMAT. Anything that requires change has people that will object, and that's the correct way to go about things. So Pharmacy Council and the National Department of Health are busy looking at those objections. And hopefully when all of that is settled, the course that the Clinician Society provides will be fully accredited, and those pharmacists that have been trained can then apply to have their qualification registered with council and apply for Section 22A15 permits. What was the second question?
What is the appropriate cost to the client for receiving ART PrEP PEP through PMAT?
So we have been approached actually by a number of medical schemes that are keen to pay for PMAT. I think the consultation is probably looking at about 160 Rand. The ARVs would be the normal price in the private sector. However, we would be looking at signing some sort of MOU with the National Department of Health, similar to what we do for family planning and EPI, in which case we would be able to supply state patients with state medicines. Thank you.
Okay, and there's a question for Maggie. Maggie, what about private pickup point in Gauteng, specifically for my region above? I'm not sure. That's from Rakesh Kumar Pada. I'm not sure which, Gauteng is.
Yes.
What about, yeah.
Thank you. I have responded to her and I've provided my email address, and then also to Princess, I've got your number, and then to Kaya as well. And I see also Miss Mocker. So I think maybe we have their details, so we'll make contact with them.
Okay. Do you perhaps want to put up your contacts maybe on the chat where people can rather call you instead of you calling them?
I did put it on the chat.
Okay. And there's a message for Sue. Can these Unjani clinics operate from private pharmacies?
Hi, Valencia. I did answer that one straight after my presentation. We have not yet tested the model in a private pharmacy setting.
Okay, and there's also Joe, I think, who has a concern. A lot goes into HIV management aside from clinical problems. They may also have issues needing mental health or addiction support. Pharmacists involved may need more training up and must be through and alert for situations that may need referral. This goes for heart, PrEP. Would PrEP include injectables once this comes into the market, each injectable PrEP?
Hi, thanks for the question. So PMAT will follow the normal HIV treatment guidelines. So if injectables are added to the guidelines, it would then be included in the scope that the Section 22A15 permit gives. So I can't answer that right now, but if it comes on to the SDG and EML and the guidelines, then yes, it would.
Okay. There's also a question for Maggie. I will be opening my clinic around June 2022. Nurse owned. I did not hear the response on how to register for Ccmdd and how do I get the updated guidelines from Jacobeth.
Thank you. I think I missed that one, but I did put my details in the chat. If they can drop us a mail and then we'll take it forward from there.
Okay. There are a few medications. This is from Numbulelo. There are a few medications that are not on sync formulary, e.g. 10 blocker, 100 milligrams.
Okay.
I don't know what that means. It only has 50 milligrams. As a result, it's not possible for such patients to pick their medications. I'm sure you can see that, Maggie.
Yeah, you see, I think also to explain to everybody as well, from this program, although it is nationally run, The provinces are responsible to put their formulary on, and we go according to that formulary. So if they could indicate which province, then we can take it up from there. Again, I'm saying I've dropped my email and I'm writing it again in the chat. Please do drop me an email and we'll attend to that one. Thank you.
Okay. I think Mr. Nchabeleng, you can run with the chat, the questions and chat on the chat box. Hey, there's one from Simone on HIV pharmacists.
I see it. I think the first one was just compliments, and then welcoming of Marlene. Veritas Reiki, excellent presentation. Jackie, Nimat, Pimat is away. Hi all, please start videos and answer questions or discuss. Oh, this is from you, Valencia. They will require, okay, this was the answer from Jackie, that they will require section 56 designation surely. It follows by, hi Moshe, okay. Are Unjani service free to clients? This was the question. I'm not sure if it's answered. Sue?
Hi, Chair. I have answered both the questions that were for Unjani.
Okay. You also answered under what permit does Unjani operate clinic?
Yes, I did.
Okay. There's a comment from Simon on which he says, on HIV by pharmacists, due to pharmacists' extensive pharmacology and clinical training, we know exactly when to refer. The idea is not to play cowboy at all, but to refer when needed, and to especially pick up those and not typically sick, unseen patients.